Okay, so my name's Rubina Ahmad. I go by Ruby, and I'm going to be talking about synovial shelving. To start off, I'm going to ask questions. Of course, you are the lucky medical students that will be answering them first. I have 6 questions. I'm going to go in order, so whoever wants to volunteer first, or I'm going to just pick them. Anybody? No? Okay, so 1, 2, 3, 4, 5, 6. Great. Okay? Down the line. Sounds great. Okay, so I've got no disclosures, no relevant relationships or affiliations with commercial interests to announce. So I had a 15-year-old female. She presented to, let's say, a PCP office, and basically my first question, if you have a second, if you were the PCP of this child, what would you want to know for left knee pain? 15-year-old female.
So when it started, what she was doing when it happened.
Okay.
She can describe the nature of the pain. Take anything for it, if it's felt or not. If anything makes it worse. What exactly she did. Like if she was playing a sport, she
right.
had a certain move or something that she did.
Okay. Very good. So kind of going down like the old cards, OPQRC, whatever you guys use. The onset was several months ago. Anterior knee pain between the knee and tibia. Duration intermittently comes and goes. She says it's kind of achy and really associated with intermittent swelling. As far as alleviated, minimal relief with, I can't use the actual name, but generics only. So, and then we've got also aggravated by repetitive bending. So she's bending, it hurts her. As far as if she had any trauma, she did not have any trauma, according to her, but she is very active. Okay, so just to answer the rest of your questions. So with knowing those few things, and she's coming into you, second question would be, what could she have? What are some differentials that you could throw out? Of course, he's going to give us the first few, and then we'll have the rest chime in. And why is that?
I guess we don't have like the full history as far as like she has fevers or like significant pain that she would be able to stand on it.
Right. So fever, she doesn't have that. Okay.
I'm trying to remember. There's one syndrome, the osgood slide about it. Yeah.
Mm-hmm. Very good.
That's all I can.
Okay. Any other? Okay. Sure.
Sure.
Okay. Anybody else? Thank you.
What was that?
Leica syndrome, the title of her.
Mm-hmm. Very good.
The obvious.
Yes, Lyme arthritis. So I didn't put Lyme arthritis on there, but that's still a good one. So fracture, dislocations, the obvious things we want to rule out first. Any ligament tears, meniscal tear, patellar tilt. You guys said kind of the others, tendinitis, bursitis, plica. And then you did say transient synovitis, so that was great. And, of course, your Osgood splatter, you said that too. And we've got our OCD also. So good. All righty. So physical exam, she was seen. Basically, at the PCP office examination, she had bilateral knees. She had normal inspection without any erythema, warmth, or effusion. And then really she had full range of motion and flexion and extension, everything. Her left knee, there was tenderness to palpation over the tibial plateau and the patellar tendon. So that's a finding. Does anybody know what that is or think what it could be? Or okay. That's something kind of like with the tendon, you could have tendinitis. So that's just something to kind of think about, this could be a tendinitis, but of course, we're still going on. Negative anterior and posterior drawer signs, that's for ACL and PCL. Negative MCL and LCL laxity, and then the negative McMurray's testing, and that's for your meniscal injuries. So they went ahead and they did a left knee x-ray about a year ago, because I'm chart reviewing as I'm doing this, because I didn't see the child at the PCP office. I saw her somewhere else. And so really, she doesn't have any fractures, no dislocations, or soft tissue swelling. And that was, I guess, the bigger thing we wanted to rule out first, especially fractures.
So,
yes.
She had enough knee complaints a year ago that someone x-rayed her, even though she's telling you a story of 6 months of knee.
Yes.
Okay.
So the other thing is, as you can see, she's had continued pain. Hasn't gotten any better. And so that's kind of where you want to go with what have you been doing, what are the things. But this is just chart review. This is all I was able to get from that. But I'm sure they asked.
The tenderness over the tibial plateau, I'm still thinking about Osgood's bladder.
Sure, yeah. Those two also.
Sorry, how active is she? Did you mention that?
Very active.
Is she
very.
An athlete who's trying to stay in her sport?
Yes. Very active, multiple sports. And so I'll get more of the HPI when I actually see the patient, because I haven't seen them yet. Yeah, true. Okay, so the other thing is, for her, she's had continued pain. The PCP is not able to, figure out exactly what's causing this. They've tried a few things, and it hasn't really worked. And so the next step for them was to send to ortho. So they sent them to ortho for ongoing left anterior knee pain because they weren't able to find anything. And then this is where I come in. So this pain has actually been ongoing for years, like Dr. Whalen was saying, left anterior knee pain, and then basically aggravated by flexion and really running, grinding. It feels like it's a grinding motion that happens. Alleviated with extension, and then there's no prior knee injury, which we were concerned about. And then activities. She plays lacrosse. She does dance. She does chair, CrossFit. Really year-round she's got exercises, and she's keeping active.
Cheering?
I think it has. No, I think it has to do with some type of flag things and stuff, or I'm not sure. I didn't understand it completely. It's an activity where she's walking a lot. No, something else. I don't know. Sorry. So prior treatment-wise, so she's done everything that her PCP's really told her. The rest, ice, compress, elevate, all those things she's been doing. She's tried a few different medications, all the generic names up there. And then soft bracing for compression-wise. And really just home exercises. She's trying to keep it simple. And when I looked to see if there was imaging, that's the imaging that I had found. It was about a year ago, so really not up to date. But she hadn't had any new recent traumas.
How much does she actually rest it?
That's a good way. But she wasn't resting it. No, she wasn't resting it, which is what we'll get to. We'll tell her, hey, ease up on the CrossFit. But so that's pretty much when we first saw her. And then for physical exam, so she had her left knee pain over the patellar tendon and inferior patellar pull, and that was the patellar tendonitis that we were talking about. Mild patellar apprehension, and this is when you have the child do full extension, or teenager, have full extension of the leg, and then you give lateral force to the patella, and that's how you really see. And that was the patellofemoral syndrome. But as far as the slight J sign bilaterally, so basically with the knees bent, you extend the knee, and then that's how you can see if there's a patellar dislocation. The knee will kind of do like a J sign, okay? Just in case if you guys hadn't seen that or heard of that.
So you're watching the knee tap?
You're watching the patella kind of do like a J.
So it falls out of the
Correct.
normal track.
So it's dislocated. Mm-hmm. And then the other thing was bilateral tibial tubercles were sitting laterally, but there was no tenderness to palpation. So if there was tenderness to palpation, you would see that would be more indicative of the Osgood slaughter. Okay? And then there's no effusion redness or joint line tenderness, posterior tenderness, or any masses that were felt. No pain with varus or valgus stress, and there was mild bilateral symmetric laxity, and that's all right. As far as there's no pain over the femoral condyles during deep flexion, and that's something that you can often see that Dr. Z was saying in regards to OCD lesions, okay? And so that's something I didn't know, so that was good That's something I can use in the future. And then pain over medial plica location. Okay, so her imaging, the one previously done, you can, actually no, we had done a new one because she hadn't had one done in a year. So if you can see, there's no OCD lesion, sorry. There's no cysts or loose bodies or patellar tilt. When Dr. Zielinski and I were looking at this, she was saying that there was maybe a mild patellar tilt to this way, but not anything too concerning. It was just very, very minimal. The osteochondritis, this one? Yeah. Sorry. My abbreviations, I know. Okay, so really the other thing, I know that we have to do this, but as far as usually anytime you get an x-ray, she believed that there would not be a fracture, there wouldn't be any concerns, but she really got the x-ray because if you want to get the MRI, some insurances would like a recent x-ray. And so that's kind of like a downfall because we don't want to radiate them. Okay, so just to go more about the left knee x-ray, so like we said, oh, I didn't show you this. So there was, oh, you can't really see it because it doesn't show up as nice, but there was a lateral displacement of the tibial tubercle, but you can't see it as well in here, sorry. And then there was asymmetric positioning of the patella within the trochlea laterally, no osteochondritis, and joint spacing is within normal, and then there was no fractures. So,
with the asymmetrical positioning, like was it on that last stone? So you're referring to the gap between the
right.
image left and
yeah.
right is smaller on the right.
Correct. But as far as the tibial tubercle, you couldn't see that as well. To see that it was displaced laterally, at least on here.
What does the OCD look like?
So for like the OCD lesion, sometimes you'll see it. It'll kind of have like a little, for the patient that I had seen, they had like a little, basically like a, kind of like a cyst-like thing over here. It's the best way to describe it. Like for me, I don't know, I haven't seen it very much, but that was the one patient that I'd seen. It was just a small, you would be able to see like kind of an indentation here.
Almost looks like a lytic lesion?
Yeah, kind of cystic-like. Okay. And then, so plan for us was, okay, no more CrossFit, no more lacrosse, mom was on board, and really physical therapy because we wanted to make sure that if this was something that could be treated with physical therapy. And also they got a lateral right wedge brace because her patella was a little bit off, so we wanted to try to realign that. And then home exercises and really follow up in 2 months and see how physical therapy really went.
I'm sorry.
Sure.
So what's your diagnosis when you're making those plans?
So for right now, we were kind of saying that maybe this is like a tendonitis versus like more so tendonitis, patellar tendonitis. Not, I mean, you could say that also. That would also be a differential. But those were the only two. Nothing else. Everything else is excluded at this point, except plica also. And with plica, I don't want to give it away yet. Sorry. Okay. And so we went ahead and follow-up appointment, I saw her. She had continued ongoing pain, and really it was physical therapy, home exercises, bracing, NSAIDs, and then taping that she was all doing. And the issue was that she actually got worse with physical therapy, and this is something that you would see most often with plica, that they do physical therapy and it's just much worse. It's not helping them at all. As for the patellofemoral syndrome, it would get better with physical therapy. So that's how we could differentiate the two. And then we talked about the medications she's tried. So on examination for her, as far as the left knee, she did have pain over the lateral meniscus, worse with the, I can't pronounce this, Cecily, there's too many S's, Cecily test, and there was also still pain over the plica. So this is a test. I'm not going to demonstrate it because I don't have that great balance, but really you would flex the knee. The effective knee would be at 20 degrees, and then you'd twist the body. And that would kind of, you know, at that point you would be retesting for any meniscal injuries, okay? Because you do that with McMurray's, but this is just to reproduce the stress. Okay, so we decided go ahead, let's do an MRI and really to evaluate for any meniscal injuries as well as for the medial plica. So I hope it turns out really nice on here. It came out. Okay. So for our patient, you see the little wedge piece up there? I don't know if you guys can see it. There's like a wedge piece right up here. And then you'll see horizontally something coming off. That's the medial plica.
Yeah.
Oh, sure. Sorry. Ta-da. Thanks. So that is the medial plica that's coming off. It ran away.
Because there's a
This thing that the mouse is on. And it's gone again. Sorry. Okay. So that's what it was. And so the left knee has a plica with suspicion for patellar cartilage damage. And I can't even tell that there's any damage there, but she could read that. So I don't know if you guys were able to see any damage. But so as you can see, it's extending also from the femoral condyle, and there was no meniscal injury. There's intact ACL, PCL. So we ruled those out as well with the MRI. And so really, it's going to talk about plica. So synovial shelving is plica. Thank you for getting it. As far as for where it comes from, it's the Latin word, plica is folding or shelving, and so there is no true folding of the synovial fluid or synovial lining, but the synovial plica is a normal structure in all of us. It's only really an issue when it becomes inflamed and really hypertrophied, and that's when it becomes more pathological to the patient. So as far as anatomy-wise, you've got the embryonic development, and you'll have the synovial membrane divide into about 3 parts. At the 12th week of life, you'll have the membranes reabsorbed, and the knee becomes a single chamber at that point. So the embryonic remnants of the membrane is the synovial plica. So that's kind of where it comes from, but the issue is to where it starts causing trouble. So there's different types of plica, and I'll show you them on an image. So you've got the superior patellar plica, as you can see it, and then it's between the suprapatellar bursa and the knee joint, and then you have the mediopatellar plica from the medial wall of the knee joint, and that the course of it goes obliquely down to the infrapatellar fat pad. Okay, and then you've got the lateral synovial plica, and that's wider and thicker and extends distally toward infrapatellar. And actually the lateral plica is more of an issue in adults. So that's, I guess, something to keep in mind if you're going to adult medicine. And then you've got your infrapatellar plica, and that's from the intracondylar notch, and it goes through the anterior joint space to the infrapatellar fat pad. So those are the images of it. Okay. And so as far as pathophysio, visually you'll see a thick, fibrotic, white, inelastic, and irregular edges, and I'll have an image of that to show you later. And then histologically you'll see fibrosis, hyalinization, and calcification. So what are the complications that you can get with this? Usually secondary synovitis and chondromalacia. So really, the irregular edges may snap over the femoral condyle, and this leads to these complications. Okay, because remember, I don't know if you guys saw earlier when I was showing you the MRI, I was saying how it crosses over, and so this could become worse. As far as what causes it, like we were saying, she's exercising a lot, so she's got repeated micro trauma for our patient, but you can also do discrete macro trauma. Embryologically, just remnants and the way that they linger on can cause it. But most often they occur in athletes with repetitive motions or any biomechanical knee stresses. But they can develop after direct trauma, like I stated, and then really a direct blow to the knee can cause this, or like a twisting motion. So basically, we don't really know. It's ongoing controversy, but as far as symptomatic and pathological versus asymptomatic, you could have the remnants from birth and not know and not be an issue, or it becomes an issue later. But the incidence of medial plica in children is 18 to 60%. And the symptoms do have a delay of onset due to possible decrease in the tissue elasticity with age, and depends on how their growth spurts also are. Okay. So symptoms that you usually see, delayed till adolescence, of course, and then you'll have that anterior knee pain that my patient was having. Sometimes you have clicking, snapping, locking, catching, and they are aggravated by activity, stair climbing, prolonged standing, squatting, or really sitting. So for her, she was saying that any time that she was flexing her knee, it was grinding, which kind of goes with the stair. So when you ask them where it hurts, this is where they'll kind of point to where it hurts for them, for medial plica. Okay, and that was something interesting because she kept saying anterior knee pain, but where exactly, they'll be able to point to where it hurts. So the medial patellar plica test, if they're in the sitting position, you basically apply pressure to their knee. So if I'm sitting, well, you can't see my knee, sorry, but basically if you apply pressure to them sitting and resting their leg, if you apply pressure here, you can reproduce that pain. And so that was something interesting because when the next patient that I had seen and I had done that to, I had a positive test, and it's something that I wasn't practicing before. So if you continue to hold pressure and passively flex and extend the knees, then you can really reproduce that pain. Okay, and so this is the same demonstration, so you can see that where the thumbs are. So there's a few things that can also occur with them. This doesn't rule out if they've got this. You don't know that they don't have a meniscal tear or a patellar tendonitis. You've got to really go further about that. They could still have Osgood-Slaughter with this, Synden-Larsen-Johansson disease, or patellar instability. And then Synden-Larsen-Johansson disease, I don't know if you guys remember, it's most often in teens with rapid growth, and really it's just a painful knee for them. As far as, I won't go into that. Okay, so medical management. Just like our other patients, you want to go ahead and treat them doing RICE, doing NSAIDs, stretching, home exercises. They can do steroid injections. But like I said, in patients, that physical therapy sometimes makes it worse. So that's when you need surgical management. But you can still try these ahead of time. Most cases will resolve by this, but you'll need surgical management. And that's when Dr. Zielinski went ahead and did plica resection, and we were able to get a definitive diagnosis because she was able to actually see it. And I'll have pictures of that to show you. And then really post-operative care, you've got your PT to get back from this, and also home exercises. And it's actually amazing because I saw actually quite a bit of patients. I don't know if you did too. And I was like, oh, that's just knee pain. It's like, no, it's plica. And so when I saw a patient from beginning till end, within their 2 weeks post-op, they were walking normally, and that they actually realized that their other knee was hurting them as well. And so I saw a patient also 3 months out from their visit, and they were back to sports and no issues or anything like that, no grinding problems. So I don't know. It was interesting. So before, I will show you on the mouse. So here you see there's the plica, and this is the patella, and this is where she was saying that there was some damage right here and along here, just kind of edges. But this is the plica that she's going to go ahead and remove. Okay, so she removed it, and she cleaned up the area, and you can see here that there was damage to the patella along here, and it's all removed out. Okay?
And the damage to the patella was because of the flight?
Correct. Remember I said if it crosses over, it can sometimes cause damage, yeah. Okay. So the clinical trials were done in England by Johnson, which showed success rate of 80% with surgical treatment, and about 50% of these patients in the control group continued symptoms later, returning for arthroscopic resection. So it worked. Complications, though, from surgery, of course. You've got your septic arthritis, your synovial fistulas. There are, septic. Recurrence is rare, though, so unless they have really an incomplete resection, then there shouldn't be an issue. And I mean, I only saw a few cases on my ortho month, but it was actually great turnaround. So of course, when you're talking about pica, your differential diagnosis, like Dr. Keys was saying, you've got your anterior knee pains increasing with activity. You've also got tight hamstrings, quads, and calf muscles. And then your plica has clicking and popping. And I don't know if you guys also remember, I said that plica gets worse with physical therapy, and this gets better. So, next question. Okay.
Do you want to go ahead and read it? 6-year-old adolescent girl presented to your office for evaluation of a right knee injury that occurred 2 days ago. She was playing lacrosse and she body with implanted. She experienced immediate onset of pain and continued steps in the hearing. She reports a sensation of touching and fire. On physical exam, there's a moderate effusion of the right knee. She's unable to flex the knee on 90 degrees nor straighten the knee to within 20 degrees of full extension. She has tenderness over the medial joint line. Radiographs of the knee are unremarkable. Of the following, the most appropriate next step in management is
No, you're fine. Which one did you pick? Sure. Take your time.
So I'm pretty concerned with the history.
Okay.
Like how it occurred, you know, during activity, and she had pain immediately afterwards. I can't remember because she walked on it right away. No, continues to have pain in his sleep during. How shall I refer her to an ortho?
Okay. So, I mean, you're not going to always refer your patient to ortho, but in this case, you would. And so if you look in the question, so she twisted her body with her foot planted. So it's like indicative. Continues to have pain with weight bearing, decreased range of motion, and she has effusion too. So that's more concerning things for me. So you're right. So I would refer this patient to ortho because it seems like a meniscal tear, but they'll most likely do an MRI. MRI was not an option on there, so that's why you went with the next best, okay? And as you can see, it's confirmed diagnosis.
In that scenario, we get an MRI 100% of the time?
Yeah. So in this question, it doesn't give us the options for an MRI, but the next best step would be ortho because these would not help the patient. It's more immediate. Okay. Sorry?
Yeah, I know it's reflexive, but it's another 14,000. Okay. You know, I just.
Yeah.
It's a great test, but in this day and age of medical cost, I would at least play devil's advocate to say.
Just go ahead and do it.
You want to make sure there's not a surgical issue, not a joint damage issue, but I think that tincture of time can be a lot cheaper too. You know, provided you're not putting the patient at risk. And so I think the orthopedist, I'd love to hear their opinion.
Yeah.
You know, just kind of get that because we tend to be okay today they need a CT and tomorrow they need an MR. Got to get an ultrasound. And we're not taught about costs. I mean, we're taught about radiation now, but I think our default a lot of times is GI too. We're just as guilty. Let's get an MR.
Right.
You know, let's get an MR. Let's get an MRE. Okay. But dang, every one of those things are, you know, twice the cost of colonoscopy. So just food for thought.
No, you're right.
I think though that it's part of their surgical planning actually. If they feel very confident that's the diagnosis.
I totally agree. I think they have to. They need a roadmap. You know,
right.
I think they need a roadmap, and I think that's a very valid point. I'd love to see the cost of arthroscopy compared to the MR, just to kind of see. It may be that we get more information from an arthroscopy in a select case and save for $14,000. You know.
That's true.
I think it's without contrast. Maybe that's what it is.
I know it dropped about $170, I think.
I think you also have to think that ACL there as well.
Yeah.
So that's going to help.
With like the twisting and popping, just to really make sure.
With an ACL tear, you wouldn't have clicking or locking motion.
You can have both.
She had
You can have
the triad.
She currently have a bucket handle there as well as the ACL. And right now the meniscal tear is what's causing her to walk, but the ACL tear could do with it.
And we have a demonstration for us. Thank you, Chuck, for being
That's
here.
in the future, I imagine at this point.
Sorry. Did you have another?
Yeah, for your patient, you mentioned that you were able to make the diagnosis before getting the MRI because of the lack of response to physical therapy. And so my question was going to be about the need for the MRI. But you kind of
Right, but there was also some concern for meniscal injury in her on examination, so this is why they got the MRI, just to really make sure there wasn't a meniscal tear. But, good point.
I think staging for differential for surgery is a valid reason. They don't want to do more or less. It might be very helpful.
Okay. Question number 2.
15-year-old adolescent presents to your office with right-sided knee pain 10 days after a basketball injury. She was running down the court during a game, came to a sudden stop and fell with a pop in her knee. The patient was seen at an urgent care clinic on the day of injury, where radiographs were performed and were unremarkable. The urgent care clinician fitted her with a knee immobilizer and recommended follow-up with her primary care physician. On physical exam, you note a large right knee effusion. The patient is guarding, and therefore you are unable to adequately assess for ligamented laxity. The following the most appropriate next step would be.
Yes.
Leaning towards the anti-inflammatories.
So, we'll go back.
I want to just go stick a needle in this and block the fluid and say that'll probably help.
So a few things was there was a pop, right? Actually, so we'll go this way. So it's actually obtain an MRI with the knee, and I'll show you why. So there's a pop, and there's also a large right knee effusion. I wanted to kind of show you the difference between the last one, because I was like, why did they go for ortho straight? But really, you wanted an MRI. And then, of course, the discussion that we had, would you really need the MRI? Why not just fix it? And so this is just to really see what it's all caused and, I guess, staging for surgery.
Well, I mean, the cost, I mean, just for the student's sake, you can get 3 ortho consults for 1 MRI. In terms of, you know, I mean, a lot, in terms of what do they charge for a consultation? You know, it's like $400 or whatever. So I do think that even judicious use of an MRI, because not every patient needs an MRI. You get a hell of a lot of orthopedic consultations and physical therapy and so on. So I just think, I raise it just to be devil's advocate from that standpoint, that an ortho consultation for proper testing, you know, might not be a bad idea.
Right.
At this point, she's 10 days out. The mechanism, the pop, the effusion are there. She's 10 days out. But show us the choices again. So nobody wants to just say, go back to playing. Nobody wants to stick a needle in this. Try some anti-inflammatories for a little while is still reasonable. Yes, the ortho referral would have been a good choice here.
I probably would have had a choice F up there, which would have been a curbside in orthopedics.
Curbside.
And this is the way that the board questions go. They don't give you the logical answer that you would follow in real life. They make you play their game. And in that game, we've ruled out A and B. D seems a little bit reasonable, but I think it's less likely given that we're already 10 days out and still there's significant.
That's the other problem. So read choice.
I missed that.
Yeah, read
You
choice.
10 days out.
Yeah, read choice D specifically. It says prescribe naproxen for 10 days. So that should be maybe 3 weeks before you had any follow-up.
I missed that we were seeing her 10 days after.
Yeah. So that itself is enough.
And then E already implies that you have such a specific diagnosis and treatment. So you're kind of stuck with C if you're already 10 days out at this point. Is how I would plan on that. Yeah, another one?
All right, and so this is explanation, but they've already done a great job already. Of course, we talked about it also. You basically want to get an MRI to look for any ligaments, articular cartilage, or any menisci injuries. Okay, so question number 3, you're next.
You're supervising an intern in the outpatient pediatric clinic. You're scheduled to see a 6-year-old girl with a chief complaint of leg pain. You review the patient's chief complaint and the signs and symptoms that will guide the differential diagnosis. Cause of pain, more or less concerning symptoms. The resident asks you what symptoms would require immediate workup. Of the following, the most accurate response to the resident's question. I'm going to go with D.
Okay. And what are you looking for in D? Okay. Good. So it was D. Okay, there we go. So this is basically, I just went ahead and put the differentials and what they were, the other options. So if you've got your knee pain with the grinding sensation, just like Dr. Keys was saying earlier, that was the differential for the pica syndrome and any overuse in teenagers. The other thing was if you have joint hyperextension, they have hypermobility, and that's when you have joint pain occurring at the end of the day, worsened with activity and improved with rest. The last thing that we commonly see would be growing pains, benign nocturnal limb pain, any nighttime chronic intermittent bilateral shin pain. But of course, anytime a kid's waking up in the middle of the night, we're probably going to be more concerned too. Okay? Anybody have any questions or concerns? Or?
Go back to the choices on that.
Sure. Nighttime knee and leg pain associated with activity, or growing pains.
Nighttime is often an additional red flag of concern. But the question was, if you go back one more page, which one of these we need to work up?
Right. And that's why it's septic arthritis.
Right. So yeah, the fever was the answer there. Nice work.
Just a comment, I would make sure for the students' sake, the residents as well, that although we're talking about orthopedic issues, we throw around non-steroidals, diclofenac, Solodac, ibuprofen, like candy. And I'm sure older people in the room here have seen gastritis, hematemesis in the fall when football 2-a-days start up, and you know, our local high schoolers are popping non-steroidals like candy. We're going to get it. We always get. We see the GI manifestations, the Maori Weiss, and so forth and so on. So just, you know, keep that in mind. Be sure that we instruct them properly about the use of non-steroidals. Make sure it's with food. In some cases, patients who take this chronically for joint issues, rheumatoid issues, whatever, it's routine from a gastroenterologist perspective to prescribe proton pump inhibitors simultaneously to give you an added protective effect. If you're going to put somebody on long-term non-steroidals, it's really I mean, data shows that I could give everybody gastritis here, saw an empty stomach, scope in 6 hours, and I already see, with that prostaglandin inhibition, I already see some superficial changes in your mucosa just from a single dose of non-steroidals. So it's something we see all the time. But we throw around non-steroidals like candy. We just need to be cautious about educating our families to not be taking this, you know, just when it hurts. You know, make sure you plan that around your meal, you know, to try to minimize some of the mucosal injury.
Take after meals, not for long-term use unless you have a PPI. The other thing is it can also cause kidney damage, and I think we've seen it here a few times too. So.
Yeah, but in fact, Dr. Keeson would say, but we had remember the one girl who went into ring that completely shut down with non-steroidal. We were at community hospital. She ended up on dialysis. You may not remember her. She had IBD.
Yes.
What's your problem with that? Just from a test taking standpoint, when I read this, I thought, oh, A is that's JRA. That's going to require immediate attention. I want to order some lab. So had I not read all those things, I mean, A does.
Yeah.
That day, I would order a Synovial therapy, you know, but D's more pressing. So that's where test taking skills are, you know, make sure you read the whole thing and prioritize. What's going to, if you miss a septic joint, that's bad. Miss JRA for another week or two.
Not too bad. And you were saying earlier when we were doing the differentials, you were saying septic arthritis, and you had said if she had a fever, then I'd be more concerned for transient synovitis or septic. So that's good that you were thinking that. Any other questions? Great.